The interesting thing is the laser stops working at this point, right? Yeah, it does. So the details that we're interested in a picture like this normally are essentially the caliber and quality of the coronary artery vessels in this patient. And so this is the aorta of the patient. This volume back here is the left ventricle. It ejects blood out the aorta, it goes to your entire body, right? That muscle contracts once a second for your entire life, right? Which is pretty remarkable when you think about it, right? It's like you're doing a curl, a very light, sort of half-pound curl once a second for your entire life, right? That's, you can't do that actually with a skeletal muscle. It will just collapse after a while. It won't do that. But this one contracts once a second. So that's about how many times does it contract over your life? Somebody shout out a guess. It's about a billion, right? It's like, that's what $1 billion is. It's every heartbeat you earn $1, right? For your whole life. That's $1 billion. So, and the great thing about this technology is you can see the entire tree of the coronary artery. And so here it comes off of the aorta, and this is called the left main vessel, because it breaks into two very large vessels, one that perfuses the front side of the heart on your chest, and one that wraps around the back and perfuses the back side of your heart that's closer to your back. This is called the left main. It's also called the widowmaker, because that's when, if that one goes down and gets blocked, you pretty well die fairly suddenly when that one is the cause of the heart attack. If you have a blockage in one of these vessels that is more distal than that, say down here, for whatever reason, the blood flow gets blocked off right there, then distal to that, farther down, you're not getting any more blood flow. And so the tissue around this part of this vascular tree will start to use up all its oxygen, become deoxygenated, and the cells become what's called ischemic, and then they start to behave abnormally, and then they eventually die, right? And so you can have a patch of your heart that just essentially dies, and that's called an infarct. And if you're lucky, you survive that, and you live the rest of your life with this patch on your heart that is scar tissue, and it's an infarct. So one of the really useful things you can do with this scanner is to take a picture like this, and if you see one of these vessels that is tightened down to a very narrow caliber, so instead of being 4 millimeter diameter, it tightens down to say 1 millimeter, that's called a 75% reduction or a 75% stenosis, and that's called a significant stenosis. That means you are at a fairly high risk of that thing closing off, and then no blood flow going distal to that. And so these are great pictures to evaluate how you're doing, right? And it takes, an 1/8 of a second to acquire the data to get an image of these vessels that look like this. So it doesn't seem to be a bad idea for somebody my age, say, just jump in the scanner and let's see what's in there. Do I have a bunch of lesions that are ready to go, or is it all wide open? It can be either one of those, right? And anywhere in between. Some people, they jump in there in their 70s and you look at their vessels and they're just wide open. There's no lesions, no calcium, anything like that. And so they're very low risk of having a heart attack. Other people, by the time they're 45, just tons of lesions in there, right? And narrowing and stuff like that. So it's, the primary way or the most probable way of dying is from cardiovascular disease. And so you have a big stroke, you have a heart attack, and you die that way. The next primary way of dying is cancer, right? So if all of us in heart disease are tremendously successful and we cure heart disease and nobody grows any lesions in their coronaries, then everyone will die of cancer, right? Which is not too great. But so now this is the machined heavy iron made by General Electric or Philips or Siemens or one of these companies that's a big iron company, right? And, they make jet engines and big turbines and things like that as well. So it spins very fast, and the inner detector, as we've seen in great detail, is like many slices, 256 slices in this case. So you can take one of those pictures in 1/8 of a second. That's what it looks like when it's getting installed. You pay about $1 to $2 million for one of these. We bought this one in 2016. This picture's from 16. We now just scanned our 36,000th patient on this scanner, right? Last week or something. So, $2 million is nothing, right? If you're going to scan 36,000 people over, 5-6 years, that's a lot of people, right? And one of the things about CT is that many of these patients, when they come and get scanned, it takes 5 minutes, right? In certain hospitals in Beijing, it takes 3.5 minutes. Like, they just have got it down to such an efficient thing that they can put through patients very, very quickly. So that's another advantage of this imaging technology, is it's really fast, and it doesn't take long to make the pictures. So here we've seen these before. This is what that 3D image looks like when you look at it as a set of slices. And a physician who looks and diagnoses cardiovascular disease usually does not look at that volume image for primary diagnosis. When they go back and they look at this thing, they do look at it, but normally it's just to figure out, did my study work out okay? Is my image quality good? Because it's very obvious very quickly. You can see the whole thing, and if something went wrong, you can see it on this volume picture quite easily. And then your trust level in the scan drops, right? But then as a physician, what they do is they come to these pictures. It's a stack of slices, and they get exceedingly good at just using a cursor and running up and down these slices like this. So they just, let's track something. So here is the aorta. It's the main vessel coming out of the left ventricle. This is that left main coronary artery coming off the aorta, right? And you can see it's pretty wide. It's 6-7 millimeters wide at this point. It's a big pipe, right? And then a physician will track that. Keep your eyes on this thing right here as we go from the top of the heart down to the bottom. They track it, just split into two, and it keeps going to split again, right? Keeps going, all the way down. So here it is here now on the front of the heart, diving down towards, and they'll just look at this data. They'll scan down and say, okay, how am I doing? How's that vessel going? And they'll follow it all the way up, say that vessel's open. There's no stenosis there, right? And they get ridiculously quick at this. So there are these contests at meetings where people that do this for a living get together, and they'll throw up a case and they play Jeopardy, right? And so to get to the question in the Jeopardy, you have to get the diagnosis on the scan correct fastest. Okay, so the contestants are sitting there, and they will do this. They'll put one of these things up, looks like this, and they'll go like this, yeah, and then they stop, and bam, somebody buzzes in and gives the diagnosis, right? So they've seen so many of these scans at this point, it just comes in, and they can tell, man, that's a right, coronary artery stenosis or something. It's pretty impressive how good the human brain is at pattern recognition, right, and recognizing things that it's seen before. So here you can see great minute details. Here's a little piece of calcium on this person's aortic valve leaflet here. This is the right coronary artery moving away. There it comes off of the aorta. It's pretty small, right? When you compare the size of this to that left coronary artery, this person probably doesn't perfuse their back of their heart with their right coronary artery, because this is such a small vessel. Goes around the back, it's up here now, right? And so they just look at that. Okay. So one of the things you can detect inside one of these pictures, and actually this patient has some, let me show you. So if I'm going down and looking at that big vessel, here it is. This is the left main, and then there's this little dot right there, right? That little dot is not a vessel. That's a piece of calcium. It's just like bone. And when you have an injury and the injury repairs, you get this sort of calcium structure that gets deposited in the tissue. It's called calcification. And that's an indication that you had some kind of injury or event here. It's now healed, but it's left behind that little piece of calcium. And here the vessel breaks off. We'll see another one, right? It's not really obvious because there's contrast in here, but it's here. That's another piece of calcium. And so this imaging technique is really good at detecting calcium. You don't even have to put contrast in the patient. You can just take a CT scan of their chest without any contrast. Don't light up the blood. And then look for bright objects like in the field of view around the heart. And you can see these things, this bright thing here, it's in a vessel, these bright things here in a vessel. So each one of these patients, this is 3 different patients who've been scanned. Each one is the same age, and they have exactly the same clinical risk for cardiovascular disease based on their age, their blood pressure, their history of medications, all the clinical stuff, right? Before you take a picture, right? And then you take a picture of these 3 people who are in exactly the same situation. This one looks like this, has absolutely no deposits of calcium in the coronaries anywhere in their heart. This person has a small amount of calcium deposited there, right? And you count up the pixels that have calcium in them, and you come up with a score. It's called the Agassiz score. This person has a score of 100. And this person has calcium in every darn vessel that's coming off the heart here, and their calcium score is 400. And so this isn't a trick question. Who do you think has the most cardiovascular disease of these 3 people, right? It's this person, right? They've been having tiny little issues, inflammatory issues with their coronary vessels and repair, and that calcium gets deposited. And that's been going on for quite some time, right? You can try and predict who's going to have a heart attack and who you should do aggressive therapy, specifically drug therapy, on these people to try and prevent them from having a heart attack. But the future is something very hard to predict, right? So you just look at them, say, okay, given your clinical, variables, can I predict that you're going to have a heart attack, right? A quick question, yeah. That's a great question. And the answer is no. Patient 3 could be, a cyclist, like a weekend cyclist who just rides their bike real fast and has absolutely no symptoms, right? And that's the difficult part about cardiovascular disease and cancer to some extent, but cardiovascular disease, 50% of people, the first symptom or sign that they have cardiovascular disease is that they're dead, right? They just die, right? And it's called sudden death. And they're, having a happy day, and they're going out for a jog, and they go, ugh, and they get this crazy pain, and then they pass out and they die, right? So that basically, not a bad way to go, all things considered, right? If you're going to compare ways to go. But if you're like in your early 50s or something, right? You got kids to send to college and whatnot, it's terribly inconvenient for everybody around you, right? So you really don't want to go that way. And so the idea is, well, let's figure out who's at high risk for having one of these sudden blockages of a coronary vessel, and we'll give them drugs to try and prevent it. And those drugs exist, which is the interesting thing. And they're actually off patent now, right? These drugs that prevent heart attacks, they're called statins. They were blockbuster drugs for Pfizer and every other drug company. They made tens of billions of dollars on these drugs, but they came off patent about 8 years ago, something like that. So now I can take a statin each day for about 20 cents, right? So, you should do it if you have these features, right? So if you count up the amount of calcium, you come up with these calcium scores. in those people who have sort of middle probability, you know, with their clinical symptoms of having an event or not having an event, some people, they have super high cholesterol. And so, you know, those people should just be on a statin. There's no question, right? Other people, you know, are, you know, the ultimate warrior athletic person, and they might not have any symptoms. But for the people who are in the middle and you're trying to figure out, you know, should we treat these people? There are all these tests that have been invented, and there's a whole list. You can look at this paper. I think, yeah, it's up here. It's a JAMA paper. Many tests have been invented to try and predict who's going to have a heart attack, right? This is the false positive fraction, and this is the sensitivity. So what does this mean? This means if I use, say, one of these tests, this is the Framingham risk score, this blue one. It's been with us for about 50 years. So you use the Framingham risk score and you set your threshold here along the risk score. You say, okay, if I predict somebody with a Framingham risk score that's here on this curve, it changes as you move on the curve, I will pick up 60% of the people that are going to have heart attacks. I'll be right about those people. You know, there's a group of 100, I'll pick 60% of them I will have been right. However, I also will have been wrong in 45% of the people who don't have heart attacks. I would have told them they're going to have a heart attack, right? So this is called an ROC curve. And if your test that you're presenting and saying people should use this test, if it sits on this line, then you can flip a coin, right? Your test is as good as flipping a coin, right? If you're on this line. If your test is below this line, you should take the test and do the opposite of what the test tells you to do, right? Because it's a negative predictor. This is the comparison of just counting up how much calcium somebody has in their vessels with a CT scan that's $100 versus all these other tests, including the Framingham risk score. And this is where it sits. And so you have a much stronger test. The perfect test sits out in the corner here, right? You get 95% prediction sensitivity to the disease without any false positives, right? That's a perfect test. No test is perfect in medicine, though. And then if you set your threshold, well, if somebody has a CAC score of 10, they have any calcium, I'm going to predict they're going to have a heart attack. You will pick up 90% of the people that are going to have a heart attack. You will have correctly predicted that. However, you will have wrongly predicted in 55% of the people that didn't have heart attacks. You would have told them they were going to have a heart attack, right? And so you get to pick which threshold you set, right? And so here's calcium 100, maybe 200, 400, right? And your sensitivity goes down, but your specificity gets better, right? This is called an ROC curve, and this calcium ROC curve crushes every other one that you can do in the clinic, right? In terms of coming up with the right prediction, sensitivity and specificity. So the question is, like, should you do a CAC scan in everybody on the planet, right? So should you get one of these CT images for everybody? And probably not, especially those people that are under 40 or under 50, because they haven't had time to develop the calcium yet, right? And so if you scan all those people, you're going to see a lot of negative scans, a lot of people with no calcium. And so it's kind of a waste of your resource, right? So who do you scan, right? Right now, a lot of people over 60 go in a CT scanner and get scanned, right? Because they've had time to develop the calcium, and now you know, should I go on a statin or not? For younger people, it's harder because it's hard to advise a 40-year-old to go and get a CAC scan, a CT scan, when the huge probability is they're going to be negative, right? So why put them in the scanner? What you can do, though, we figured this out with genetic data from 23andMe. So you can derive a cardiovascular risk score based on the SNPs on the chip that 23andMe uses to determine those people who have a high probability of having cardiovascular disease when they get older, right? And it's a pretty strong predictor, the genetics, right? is a pretty strong predictor. So what you can do is with these young people, you take their 23andMe chip and you use the SNPs on that chip to predict who will probably have cardiovascular disease in the future. And it turns out it also predicts who's got calcium now, right, when they're young. And so you can just, for people that reach a certain level of risk with this genetic test, that group, you can say, okay, you guys should all get calcium scans because amongst you, 25% of you are going to be positive, right? As opposed to any old group of 40-year-olds, 3% of them are going to be positive, right? But this group, 25% will be positive, so that's the group you should scan. So the combination of those two tests together is a good way to go. And so, we showed that with this genetic risk score that you develop from these SNPs, there's a group that has, a 3x times higher probability of having calcium than their age equivalent group, right? Based on their genetics. So you can set up say, okay, here's your genetic risk score. So this person has very low genetic risk. Well, they can wait till they're 52 to get their first scan. This person has high genetic risk. They should probably get a CAG scan at 40, right? And then if you know you're growing disease, then you can grow on a statin, right? The other thing is to look at the actual morphology of the lesion itself. So now you have calcium. It's been detected on CT. So here's a piece of calcium. This is the left main vessel. It breaks off into basically the LAD, the circ. So this is going to go down, perfuse the front of the heart. And then you have this little dot here, which, when you look at this image, yeah, you guys can see it pretty well. This is not random noise, right? I mean, remember we talked about manufacturers doing filtering and messing with the raw data such that when they did their convolution back projection, plus whatever they do with their raw data, they get something that looks like this, right? So it's got this, you can see this correlated swoosh pattern along here. So there's a lot of smoothing going on in this, right? However, definitely, smoothing or not, you would call that a positive signal. I think we'd all agree, right? It's bright enough. It's not some random thing. So when you cut the vessel along its, the orthogonal direction of its travel, treat it like a pipe. A over here, when I cut this and look from this direction, this is what the cross section of the pipe looks like. This is aorta over here. This dark stuff around it is actually fat. Remember when we looked at Hounsfield units, how fat had lower Hounsfield units than muscle, which is this stuff out here, right? And so it's dark. It's embedded in this really hard, pericardial fat. It's kind of interesting. When you hold a mammalian heart in your hand, there are these grooves that the vessels run in, and inside the groove is packed with this really hard fat. And the vessels run through that fat. And when you push it with your thumbs, it's like solid, right? Hard fat. And some people are looking at the composition of this fat as another risk factor for developing lesions. And so you can measure, given the Hounsfield units in this fat, you can measure different sort of characteristics of the fat with CT, and you can do that with MR as well, if you have patients. And so here, looking at the axial cut through this vessel, we can see the lumen is still very large. That's not been narrowed that much, right? But there is this chunk of calcium right there, right? So something happened there. And then down here, the vessel is smaller, obviously. And in fact, if you look at this part in the axial cut, this is the LAD taking off. This top one right here is this thing. And down here, it's the circ. This is the circ. It's not perpendicular. It's at an angle. But now the LAD is pretty small, right? Compared with the main or the proximal LAD. This is a stenotic region in that blood is coming down a tube. The tube gets a lot smaller, and then it gets bigger again. So it has to get through this small part, right? So this will be, it probably is not a flow limiting region yet. So this person can run as fast as they want and they're not going to feel any pain or anything like that through ischemia, but it's smaller than the surrounding stuff. And then, so there's the reason why you want a high resolution CT scanner. So as engineers, we're asked, you know, okay, CT is great, build me one that has twice the resolution. How much is that going to cost, right? And that's like a common ask, right, of engineers. Like, I want something with twice the resolution. How much will that cost? Does that cost 10 times more? Does that cost 2 times more, right? And so this company, as we saw, built a scan with twice the resolution just by increasing the number of detectors and making a X-ray tube with a very small spot size. And now you can see that little piece of calcium and the soft plaque around it in much better detail, right? And so you have features that you can recognize and characterize, and then that little piece of calcium is much more detectable than it was on the lower resolution scan. So here's a little dot, shows you the size of the soft plaque around the dot. And, you know, it should probably go along that way, right? And so this lesion is taking up that much space in that vessel. If I drew a straight arc from here to here, you know, it would take that out. Here's a comparison of the high resolution, middle resolution, high resolution, middle resolution. This one you can see, you know, this one, it's hard to even tell if there's something there, but anyway. And then you can also do it in the slice direction, right? Where even on our scanner, which doesn't have the double detectors, it just has a, you know, 0.6 millimeter slice and 1 millimeter in plane. Traditional calcium scanning, because it was done, it's been done for about 30 years or something. When it started and they had their protocol for doing this, it was a 2.5 millimeter slice thickness. 2.5 millimeters seems like a pretty thin slice. And back then, for any kind of imaging, that was a thin slice, right? But now we're up to slices that are below a millimeter. And you can then start seeing these smaller, earlier pieces of calcium in people at younger ages, right? So you don't have to wait till the person's 55 to see the calcium. You can see it at 45 or 40 or whatever, because you can detect it with this thinner slice. Whereas this slice, you just don't see it. It averages out, right? This is the exact same data. This is not just the same patient, it's the same data, right? And when it's reconstructed as a calcium scan, they use this, and then they give that score, that CAC or CAC score. Here, that one didn't even show up. So the question is, how many people? So if you look at people between, I guess this data was between 40 and 60 or something, and you say, well, here there's average ages up here, right? Yeah, that's what this is. So this histogram shows in a group of people, like, how do their calcium scores break out? Okay, so this group, calcium score 1 to 10, that means just a little bit of calcium. And then we're going up in numbers until finally you get up here. These people have a lot of calcium. They're very old. 71 is the average age in this histogram. And down here, but the question is, once you get below 1, what's happening between 0 and 1? Because so many people have 0 in this group. So you scan them, you say, you don't have any calcium, right? It's 0. Is it? Right? So the question is it really 0? Because if we had a scanner that was higher resolution, wouldn't we find people that would go in this box right here, which is between 0 and 1, right? So how many people sit in that box? Nobody knows, right now. This is a guess, right? Just say, oh, well, I guess it went like this. Maybe it's like that. But I don't know. You're taking it from here, right? We do know that every 10 years of life, the frequency of the calcium you find in people, these are people between 35 and 45. So about 12%. And then by the time they're 45 to 54, about 25% of people have calcium. So it just doubles the number. So, so these people, the extra people that you find once you start scanning them at 45, they probably had calcium down here. You just didn't see it, right? So that's the question. That's where technology improvement, and outcome mixed together. You say, look, if I get a higher resolution scanner, I'm going to detect these people sooner. And then, so what? What do? Well, if you put them on statins, it turns out your lifetime exposure to LDL is the thing that is the total risk when you're sitting at 65. So if you drop that exposure over your entire life, then your risk goes back to almost like normal, right? When you get to 65, if you've been doing these drugs for that long. Although statins, I mean, it was so obvious, and it has been obvious from many, many trials that they work, but some professors at Stanford got in horrendous trouble for telling a class of medical students that statins worked, right? And they, just blah, 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 blah. And then it was found that they were on speakers bureaus or something of Pfizer or something like that. And the students went crazy, right? They said, oh, you're on the payroll of Pfizer. We don't believe, this data, blah, 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 blah. And you're like, okay, you're medical students. You can believe that statins don't work if you want. It was quite a brute. You could look it up. It's good fun. So anyway, this is showing that you can acquire these coronary CT scans where you need this high resolution and very, non-blurry pictures. And you can acquire them at a really low X-ray dose. And principally in people who are pretty thin, right? So this person, the body mass index is 27, which is like, it's like me, right? My body mass, I think, is 27, right? So if you're a normal American, like, and you're bigger and heftier, then your body mass index will probably get a 29, 30, something like that. And as you get bigger and heftier, what happens is the energy of X-rays you need to use to make the picture goes up, because you need higher energy X-rays to get through the patient, right? To hit the detector, and therefore dose goes up. But for a lot of people, you can get pictures like this of their coronary arteries for 0.3 millisieverts. And if you go back like 6 lectures or something, the dose that you receive just being alive and walking around for 1 year is 3 millisieverts, right? So it's 1/10 of that accumulated annual dose, right? So if you did an experiment and you gave people a CT scan and had 0.3 millisieverts, and you gave 1,000 people a scan and 1,000 people no scan, I defy you to detect a difference in survival between those two groups, right? Because you've got 3 plus or minus whatever millisieverts and 3 plus or minus whatever millisieverts in the other group. So it's very difficult once you get to these low doses to evaluate. Like, if I go from 0.3 millisieverts to 0.6, even though the increased risk in cancer, if it existed, was X, would it then be 2X if I go to a 0.6? We just don't know. You can't measure it down there. Yeah. Well, the ethics are, suppose we want to perform a study where the CT scan for somebody is not necessary for their healthcare, right? For their progress through, treatment or whatever. We're going to do the scan to prove that you can measure, coronary vessels with some kind of accuracy. And this would require an extra scan on some extra special CT, right? And you're going to compare them. So that extra scan, say it's 3 millisieverts, you then go to what's called the Institutional Review Board of your institution. And this is usually about 12 to 20 faculty members who do clinical research and stuff like that. And they look at the risk-benefit ratio of doing that study. and they evaluate, is it worth 3 millisieverts to figure out whether or not this thing is better than this thing, right? And so you just write it all down very explicitly. They debate it. They come back. They usually say, you need to give us more information about this and that. You put it back in, and it comes back. And then sometimes it's approved. And for the most part, in fact, all of them, if you give an extra scan or any kind of extra study, you have to also have evaluated by the IRB a form that is a consent form. And that form has to be in multiple languages and approved such that it's understandable. So you can't just put a consent form in front of somebody that's a bunch of medical gobbledygook that they're not going to understand. You need to explain specifically what's going on, and you need to obtain their signature before they do it. And so that's called an IRB approved trial. And so any NIH grant that we have here, when humans are involved, it's always under one of these IRBs. And you have to have that in place to have the study done. When I was younger, that wasn't the case, but now it's very, very strict. I mean, we just used to jump in not a CT scan. We didn't jump in CT scans, but MR scans. I've been scanning an MR scan, I don't know, 500 times, something like that. I've probably had 500 MRs in my life, and I've run some of them. Like I've been in the scanner, it's late at night, and you have a keyboard next to you. You stick in there, and you scan something, and then you look and go, "Oh, that didn't work," and then you do it again. Yeah. I had a special scanner that was really short. So the other thing about this is that nowadays it doesn't matter that the patient's heart rate is really high. This used to be an Achilles heel of CT, is that you needed to do multiple rotations to gather up all the data to get through their heart. And now that you've got this big wide detector, you just need one rotation. So it kind of doesn't matter that their heart rate is high, and it doesn't matter that their heart rate is variable, right? Both of those things matter for scans that are done with any kind of gating from beat to beat, right? And so MR requires that. So here's a patient who's in atrial fibrillation. That means their normal activation pattern, their atrium going through the His-Purkinje system, et cetera, isn't working right. And their atrium is just sort of sitting there fibrillating and not really contracting in a concentric way. And so that produces an ECG that looks terrible, right? You've got a really long delay between this beat, and then shorter, and then even shorter. And so that it's highly variable. We kind of don't care when we can do everything in one heartbeat, because you just acquire one of these triggers and then get all your imaging done at some delay after that trigger. It doesn't actually matter that all of this garbage is here, right? So again, it gets around that problem, which is a big problem. Some CT scanners that have not the full 256 or 320 slices, so the question is, why do you make something so big when you can just do a helical acquisition with this multi-heartbeat problem? And so this scanner is a really cool scanner in that it has 2 X-ray tubes and 2 detectors. Remember this one had 90 degrees apart, so it can gather data twice as fast in one rotation as one that just has 1 X-ray tube. However, the detector is thinner, right? And you can actually see how thick this detector is, right? If you look at this scan, okay, right here, do you see this band right there? That's how thick that detector is, because this was taken on a different heartbeat than the stuff around it. And that heartbeat was different. And this is the artifact that you see. You see this different sort of dynamics moving up through the heartbeat. So this was done as a helical acquisition. So in my mind, if you're going to do images of the heart that involve function like this, you really need to have one of these scanners that captures the whole heart in one go, right? It's worth the extra cash if it's money we're worried about. Although those 2 scanners are the identical price. The other great thing about CT is it doesn't really matter if you have a lot of hardware in the patient. unlike echo or MR, where a lot of this motorized hardware it's pretty hard to do an MR scan when you have all this stuff in there. It's not advisable to put the patient in a magnetic field, probably. So in the raw X-ray, images, you can see the components of this thing, and this is called a left ventricular assist device, or LVAD, and it's like a pump, and it takes over from the heart when the heart completely fails and it just can't pump anymore. This thing can take over, and it's like an artificial heart. And it's plugged into the apex right down here of the heart, and you've got the pump here, and you get a bypass from over here, and you just push the blood through the pump here, as you can see, right? And it's great. You can image it while it's working. You can measure how the installation and everything went and stuff like that with CT, which is terrific. So let's go back to this question about using CT to determine the course of healthcare for lots of people. And this is just a statement in JAMA about the effectiveness of statins. And so given all of the clinical trials that were run up to this point, this U.S. Preventative Service Task Force, which recommends behavior or recommends what treatments should be offered and what screening should be done in patient populations, right? And so their recommendation you're welcome to read the whole paper, is that if your calculated 10-year risk of having a heart attack is 10% or greater, then you should go on a statin. Okay. And so how do you put those people into that group that they're 10% or greater? There's lots of parameters you can measure. Their blood pressure. Principally, the one that correlates the most is their LDL in a blood test. It's the cholesterol, low density lipoprotein cholesterol. And if you have high LDL, then you have much higher risk of having cardiovascular disease. HDL, it turns out, doesn't matter. So that's called good cholesterol. And if you have high HDL, it's shown that correlates with fewer events. But it actually isn't the high HDL which is causing it. It's causing the fact that the LDL is actually lower in those patients, right? That was just recently proven with genetics. It was believed for many, many years that having high HDL was a good thing, but it doesn't matter. But there's an interesting, when you have the ability and you have an imaging technique that can actually look at the patients and decide who actually has coronary artery disease, right? As opposed to using clinical variables to determine who's at high risk. Let's just look at their coronaries and see who has disease, right? And so you take a group of patients and you image them all. And these are people that had no previous coronary disease. They're sort of middle risk clinically. And after we take their scans, we can put them in 3 buckets, right? We have one bucket of patients that had absolutely no coronary disease seen on the CT. They're clean, right? Just like that one that we saw at the beginning. Then there's a group that has what's called non-obstructive coronary artery disease. And that is the vessels aren't closed off, but they're narrowed down to anything below about 80% reduction, right? So that's coronary disease. It's obvious it's there, but probably isn't flow limiting yet. And then you have one bucket, this poor 20 people here have obstructive disease. And that is when you look at the CT scan, the vessel is just tiny. Like it goes down to about a 90% stenosis, right? And they're still walking around, just they don't know it's there, right? The color here represents those folks who qualify to go on a statin using this ASCVD risk score or risk calculator, which uses clinical variables to decide who's going to go on the statin. So let's look at this group first. This is an easy one. 30 people in that group actually were recommended to go on statins. And that probably, even though they don't have coronary disease, that probably is not a bad thing if they have high LDL, because you want to bring down their cholesterol, right? So that clinical variable you'd like to bring down. What's interesting is the people who actually have coronary artery disease, so you look at their vessels and they have disease, half of them qualify to go on a statin, half of them do not. So this is saying with this score, don't put them on a statin. And you look at their vessels and they're growing lesions. The question is like, does that make sense? That if you're growing lesions, should you not go on a statin? And you go to the people who have severe coronary artery disease, and 7 of those out of the 20 didn't qualify to go on a statin. And that's ridiculous, right? So at that point, you're just like, nah, this is crazy. So to me, it makes sense to have this image. Yeah. Yes. Yeah. So the question was, are there alternative treatments to just taking a statin if you have coronary artery disease? Yes, but they are lifestyle changes. Principally, quit smoking, right, is the number one thing to do. And that if you look at people quitting smoking, that their survival goes much better. And then diet, right? And so dietary modifications can decrease your LDL just by eating different food, right? However, not by much, right? So you can get your LDL, and don't quote me on this, but there's lots of papers that you'll get your LDL down 10% if you're really, really stringent about just eating spinach, right? And, no steak, no eggs, stuff like that. Yeah, then you have other problems. But anyway, people, like I know people who the statins don't really go well. They give them side effects, right? And some of these side effects are not comfortable in any way. Like you get really sore legs even when you're resting and stuff like that. So they have got rid of the statin, and they are like really stringent about their lifestyle and food and exercise and stuff like that. So all of that goes into it, right? But a statin is a very powerful drug. You can, just by increasing the dose, your LDL just keeps going down. They now have these PCSK9 drugs, which you inject, and they can get your LDL down to just floor level, right? Really, really low levels of LDL. And when they do the statistics of decrease in risk of events as a function of dropping the LDL, they still haven't found it bottoming out. If you make the LDL go lower, your risk continues to drop, which is fascinating, right? So if you can tolerate a statin, there's no question that that's the way to go nowadays, especially with it's off patent, right? So there was a big, let's go back to imaging. And there was a big trial to determine which imaging technology is better in order to determine who should go towards interventional cardiovascular therapy versus not, okay? And so the other thing you can do if you use it, well, this is a complicated thing, but if you've got a really tight stenosis in a vessel, you can insert a catheter and a guide wire down through the stenosis, and then across the guide wire, you put a catheter that holds inside it a little mesh thing called a stent, and then you inflate that stent, right, such that you regain the original diameter of the vessel, and then you pull back and you leave the stent there. And so now you have a vessel that's its native width, right? So that stenosis is now gone, right? So that's interventional, it's called PTCA, done in 2 million people a year in the United States, something like that, done a lot, right? And it will save your life, no question. If you wind up in the ER and you've got crushing heart pain and you've got EKG abnormalities and you're having a heart attack, that is the vessels closed down tight enough that you have ischemia in your muscle. Definitely, no questions asked. You should go into the cath lab, right, where they have x-rays and and they put catheters up into your vessels and get that thing open. Put a stent in there and get it open, right? If that's happening to you, because your rate of survival is much, much higher than just, toughen it out, right? And you can just tough it out. Lots of people do. We've scanned people where it's obvious there's a big old infarct in their heart, and we say, did you ever have, a history of heart disease or something like that? I said, no. I said, well, you ever had chest pain? Oh, yeah, a couple times. But just muscle through it. It's like, oh, good. I'm going to sit down. And then, the next few days you just recover but you've got this big infarct in your heart. It's pretty amazing. So, question, you got these people who are at middle risk of having heart disease, and probably you're trying to determine, should they go to the cath lab or not? Because when you get into the cath lab, you can get these fantastic pictures of their vessel, and you're in a place where you could open it, right? If it's really tight. So everything's good there. You might, but who should you take to the cath lab? And so this trial was like, let's consider CT first versus nuclear medicine. So as engineers, we're like, oh, great. This is like, the robot wars, right? It's like, is my CT scan going to crush the nuclear medicine scan in terms of ability to predict who should go to the cath lab, right? And it's cool. This is these studies are really expensive though. Look, 5,000 people went to CT first, 5,000 people went to nuclear medicine, right? And did a traditional stress test. How do you get numbers this big? This is done all the time, right? In the United States, I don't know how many, 12 million of these things are done a year, something like that. It's just a huge expense for healthcare. So, and this is like my little cartoon of how this trial went, okay? So of the 5,000 people, 4,692 that went through the stress test arm, 406 of those people were determined to be positive enough, or it looked like there was a blood flow reduction on the nuclear medicine such that they recommended that person go to the cath lab, because they're pretty sure there's disease in there. And if you go to the cath lab, you're going to see the disease and then you might fix it, right? 406. On the CT arm, right? Same number of people, exactly the same statistical cross-section of people. CT found 609. They said, you know what? There's definitely disease here. Should go to the cath lab. And the disease is severe enough, you should go to the cath lab. So obviously, right out of the box, different behavior, right? So there's a group of patients, like a dashed line, that's how many is different from here to here, that wind up in this green box. It's like, nope, you don't have disease, or it's not severe enough. You don't need to go to the cath lab. Two of my friends weren't in this trial, but went down this pathway because this is the common pathway, wound up in this box, right? And both of them knew they were not normal, right? One guy was a cyclist. He used to ride, 110 miles on the weekend, and he couldn't all of a sudden, it was just like, he would start falling behind the group, blah, 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 blah. It's just like something's wrong. And then another guy who wasn't really an athlete, but was just a normal person, had one of these stress tests. They cleared him, said, you're totally normal. 4 weeks later, he was in the hospital, having a massive heart attack, right? So so that can happen. So anyway, let's look at what happens to the 400 people that go through this nuclear medicine scan. Here's the winning robot wars part. When you get in the cath lab, and this is the truth, like you inject the dye and say, okay, where's the disease? Of the 406, 213, when they injected that dye and looked, there was no disease. It was just wide open, right? So they got it wrong somehow, right? So that's called a false positive. 193 people, they did see disease, right? And in 120 of those, they did this stent. They put a stent in because it was severe enough. And in 38 of those people, they did a full coronary bypass surgery, right? So that's that group. Over here, when we looked, in the cath lab, how many of these people have disease? 439 were positive on cath. Okay, let's pause for a minute. 439 versus 193. I think we left a few behind right over here, right? They're up in here, right? And over here, they're in the cath lab and they have positive disease, right? However, still with CT, but this was 10 years ago, so it was early on, and a lot of the readers and things on this CT had less experience, and so they would overcall to be maybe a bit more safe or inclusive. And so there's still 170 people, when you put them in the cath lab, they were normal, right? So as engineers, right, that's our problem. That's what we got to solve, right? You got to make better pictures such that this doesn't happen, right? We're picking up more disease. That's good. But for some reason, this is still happening. Stuff looks like disease that isn't. And so that's an engineering problem, right? That's like, we got to get rid of whatever artifact that is. Yeah.
I believe that not single cardiologist.
Right. So this study was huge, and there was probably 100 clinical cardiologists participating in this study, and they all have different patterns of deciding what looks abnormal and what looks normal. And so you're absolutely right. Aggressive physicians who they'll call stuff abnormal more quickly, right? And so there's a spectrum. But even still, like, you have to take that into account. This is the real world. And our scanner that we built and showed this person who's aggressive, we should just be better at making a picture that they cannot confuse, right, with abnormal, right? And it, some might be hopeless, but it shouldn't be this big, in my opinion, right? Not only that, there's an interesting corollary to that, in that there's 170 that were normal. And then of the 439, they did 236 stents, which is a lot more than this, right? They did 75 bypasses, which is a lot more, it's double this, right? But not everybody got treated that was in this group, right? So they were positive on cath, but they weren't positive enough on cath to actually do a treatment. So why are they in the cath lab? Those are another group. As engineers, we could say, even if they're positive, we should be able to tell the physician they're positive, but don't take them to the cath lab because they will not put in a stent or they will not do bypass. So leave them out of the cath lab. We're done now, right? So there's a big group of images here that, as engineers, we can make better, right? The interesting thing about this study, and this shows you the strength of the nuclear medicine community, this study was deemed that each pathway was equivalent. That if you were a patient, it didn't matter which one of these pathways you went down. And the reason was, at the end of the day, the number of people that died in each pathway for this trial, because we wound up with so few people actually being treated, the number of people that died in each pathway was not, it was a little different, but it wasn't significantly different, right? It has subsequently turned out in bigger trials, different trials, that there is a difference, right? However, the conclusion, read the conclusion in this paper, is that, oh, these two pathways are the same. So as a person who built the robot in the robot wars, is like, what? We crushed that robot, and yet the outcome was, oh, well, everything's the same, right? So it was a little frustrating in that way. This is called the PROMISE trial. It's a good paper. So this is actually a very interesting, we're going back to our old friend here. This is the what are these called? U.S. Preventative Service Task Force. And these are the folks in the government that look at all the publications and decide what to recommend in terms of screening. And so for heart disease, it's very interesting in that they didn't recommend screening for heart disease with any technology, with EKG, with EBCT, which is electron beam CT, which is like coronary calcium scanning. They thought the risk of overtreatment or false positives outweighed the risk of finding those people had disease. And therefore, they don't recommend screening, right? And that's their official stance. And then there's this little clause down here that says, reasons to consider screening on an individual basis, right? And there's some reasons like family history, etc. But this is my favorite. It says, select occupations such as pilots, where sudden incapacitation or sudden death may endanger the safety of others. No, well, I mean, without any irony whatsoever, they just like, yeah, in important people, you should screen them, right? Right? Important people like pilots. And you know, when you're in your car driving down the 5 and you've got your friends or your kids or something, who's the pilot now, right? So for you, when you do your betting and statistics of what you should do for your healthcare, this stuff is junk, right? This means nothing. What this means is like, what should a insurance company or a healthcare system recommend for the system? Not for you, right? It's like on average for the system, what should it, right? Because it's so obvious that you can determine who's at high risk for having one of these events. But if you're not an important person, then it doesn't affect the system, right? Yeah. Yes. The one thing that changed between now and this was the American Heart Association 4 years ago, I think, just caved and said, look, the data is just way too good. You should have a calcium scan, right? If I'm in the office with my patient and I'm in the balance, should we go on a statin, not on a statin? I don't want to send you to the cath lab because that's a big deal. Let's have a calcium scan. 5 years ago, that was not the recommendation by the American Heart Association, or I think the American College of Cardiology, neither one, but now it is. And since I've been here, like we used to get a calcium scan every 4 days, something like that on the scanner, maybe even less. And now we have 4 a day, 8 a day, something like that. And that recommendation, just flipping that recommendation, the physicians felt really comfortable starting to order it, right? The test, even though we all knew, like way ahead of time. So this is an interesting thing also about American medicine that you have to keep hold of, is that it will take a generation of work to make physicians change their behavior, right? Unless you get a recommendation from some body on high, they won't change the behavior, partly because they won't get reimbursed, right? Because it has to go through this whole approval by insurance companies and everything to get reimbursed. So, and if calcium scanning took 25 years for this to happen, and it was so obvious, you saw the ROC curve, right? That it was a better test, that it's really hard to imagine, like when you get some really sophisticated test, right? So here's an example of a stenotic vessel easily seen on a CT scan. Here's the proximal portion. It gets narrower here and it widens open. And then if you look in the orthogonal direction along this purple projection, it looks like this, and it's narrow in that direction too. So we cut the vessel right along the axial direction and look at the pipe. And so here's the pipe at this location, and it's narrowed down to about 1 millimeter in diameter, and it started out at 4 over here. So it's like a 75% stenosis. And you would think, oh, okay, well, as a physician, I'll just draw my cursor and give quantitative information about the vessel. That is never done, right? Physicians don't do that. They look at it and they decide from pictures like this, they characterize it as a significant stenosis marginal stenosis or normal, right? They don't go in and make the measurement. And the reason is interesting, and you guys understand the reason now, is that it's because when you look at this signal, it's kind of blurry, right? This is 1 millimeter, and we found that the point spread function of the average CT scanner is like 1.2 millimeters, right? So it's a Gaussian of 1.2 millimeters that gets convolved over everything and turns it into this blob. So as it gets smaller than a millimeter, it actually doesn't change its shape anymore. It just gets dimmer, right? And so measuring this distance when you're down around the point spread function isn't a good idea, probably, right? And so one thing that's done, though, is this company performs what's called fractional flow reserve using a computer model, a computational fluid dynamics model, where they take the CT, they segment out all of the vascular structure. They then look at how much myocardium is downstream. So if you have twice the myocardium, you're going to need twice the blood flow. So they put that in the model. And then they run a huge computational fluid dynamics simulation about blood flowing through those tubes. And they predict how the pressure will drop as you go down those tubes, right? And the output looks something like this, where you see normal pressure drop at this stenosis here. And so here, the pressure is 0.87 of what it is back here. And it turns out that when you do this with an actual pressure catheter, you can show that if that pressure drop is more than 20%, i.e. that value goes down below 0.8, you should probably stent that vessel. And this is what's used now to make that decision, right? And so this is an ongoing company. It's called HeartFlow. Fantastic business model in that they made you, as a user, upload your raw data to their server inside the company, and then they did all the segmentation. And then they would bring you back a report that looked just like this, right? It came back the next day. Now it comes back the same day, I think, because I do believe they probably don't do hand segmentation anymore, because they have hundreds of thousands of cases that they did manually. So what are you going to do with that data? You're going to train a network to do that segmentation, right? Maybe not even train a network to do the segmentation, train a network to make the pressure like estimates, right? Forget the CFD calculation. That's expensive. Now I can just have a deep learning network just look at the vascular tree and make that map, right? And so their turnaround time is very fast now. So I'm assuming that's what's happening, right? And you know, it was a great business model. It's all their data at this point, right? This is what that lesion looks like on X-ray, and you can see the detail you can see on X-ray. It's fantastic. And if it was significant enough, it turns out that this was not significant using that flow, computed the flow with CT. The pressure drop was 0.87. The pressure drop measured with a catheter inside the vessel was 0.87 or 7.9. And so it wasn't enough to do anything with this lesion. You just leave it, put the person on drugs, right? Here's you know what? It's late. I'm going to just zip past this too. There's technical stuff about the point spread function and motion, and how the point spread function changes with motion. But let's go forward. Okay, because this is really one of the reasons why you want a really high resolution CT scanner. Okay, so we can see these pieces of calcium on the scanners we've got, but there are other characteristics of these lesions that show up in coronaries, like this one here has, it's called positive remodeling, in that you can see it causes a stenosis, but more importantly, it has a very large volume on the outside of the vessel, right? So even in the cath lab, when you inject contrast, you'll see a very minor stenosis. But on the CT, you can actually see the lesion itself sitting on outside the vessel. This is called positive remodeling. Here we can see the composition of soft plaque and calcium. Calcium is a little hard to see. You can see it on coronary angiography, but it's a little more difficult. And then there's some very interesting other morphological ways lesions can happen. For example, this one's called the napkin ring sign. And here's basically the lumen of the vessel. This is where the blood is going through, but the whole vessel is this big, and this is the lesion. And you can see that there's a dark spot right here, right? And that is presumably the lipid core of this lesion, which is a fairly young lesion, which has a high probability of rupturing right about here, right? So this, if you see this pattern, this lesion has a much higher probability of causing a heart attack than, say, this one, right? Calcium, the amount of calcium actually predicts the fact you're at higher risk, but it's kind of an accumulation of statistics saying you are generating lesions at a high rate, right? The calcium itself doesn't really present a risk, right? In fact, it stabilizes the vessel, if anything, right? But these other patterns of how the plaque is distributed inside the lesion are things that have been shown to actually have higher or lower risk. And so that's why you want very good motion correction algorithms, because if you're going to image these things at super high resolution, remember this is about 2-3 millimeters across. So this thing here is under a millimeter. And so we want a point spread function that's probably a 0.5 millimeter, right, to image that thing. So we need to get the resolution up. And so we need to image it either really fast or we need to correct for the motion, because it's going to move a fraction of a millimeter over the course of the 200 milliseconds or whatever we're imaging it. And so you need to get in there and correct that as well. So the folks who picked the motion project, you're going to demonstrate what does motion artifact look like in CT. It's a really important understanding for making high resolution pictures. You can make pictures of ventricular function, where you have a volume full of blood and then a volume after it's been ejected, and you can calculate the ejection fraction. You can just visualize the function like this. We've seen this before. And that's volume as a function of time. This is what the inside of your left ventricle looks like. This is a human left ventricle filled with a clear fluid that's oxygenated. And then a picture was taken with a camera, right? And so it's got all of this, trabeculated kind of tissue all inside the left ventricle, right? And the great thing in CT is you can actually image that structure, not so much in echo or MR, and you can track where that structure goes as the heart contracts, right? And so you can look at features and track those features, right? And then using an algorithm that tracks those features, you can calculate a vector field of how all the points are crushing together, and then plot out as color the local function of the myocardium. So this blue tissue here is contracting down over the heart, right? So this is like end diastole, and then the heart starts to contract. All of this stuff contracts. This does not. So there's some abnormality there. It's just sort of bulging out, right? So you can measure like really precise function as a function of position in the heart. And this is data that was taken to compare it with MRI. These are MRI pictures with tagging on them. And then if you plot how much strain, like the tissue goes from a patch down to a patch that if you measured in one dimension on that patch, it's 0.8. So it crushes down by 20%. And this is 20 people overlapped on one another at different positions in the heart. So it's very reproducible. And you can come up with basically a curve that says, well, you're normal if you fit inside these lines, right? And you just take a heart in this person, and this person doesn't fit exactly inside those lines. This heart is probably even though it's generating a lot of strain, it's got a strange relaxation, sort of delayed relaxation. And then we'll do one more thing. If if you can come up with a technique where each scan you use very little radiation, I'm not talking, 0.3 millisieverts, I'm talking like down to 0.1, 0.05 millisieverts of radiation, then we can take pictures over the course of, say, an injection of a contrast agent, right? And so that's what's going on here. You see the contrast agent comes on the right side of the heart, and then it comes back into the left atrium and the left ventricle, and then up here. And then this is over the course of 20 heartbeats. And each scan we've acquired on an EKG gate. So the heart's in the same configuration. So you get this nice change in Hounsfield unit as a function of time. And you can plot that as a little graph, and it will tell you a lot about the flow at that location, right? Just how much contrast agent is going in there and then coming back out. So you can get these dynamics, right? And whether or not the perfusion is normal. And I'll just show you one interesting picture. So this thing up here, this is the left atrium, this little chicken wing thing right here. And you can see it is the source in people in atrial fibrillation. 90% of strokes in those people come out of that little pocket, right? Because this is like the side pocket off the left atrium. And so blood goes in there, and whether it stays in there or flows back out is dependent on the function of this thing. So you can see here, it's aggressively ejecting blood out. And I won't go into all this, but I just want to show you some data for how you measure using an injection of contrast. You can see how the proximal portion of that chicken wing fills first, and then it kind of moves up to the distal portion later. So that kind of delay, and whether or not the blood hangs around for a long time in the distal portion of this, will correlate with whether or not you're going to generate a thrombus at that point, right? So all of these kind of dynamics you can measure if you're willing to inject a contrast agent and see the pictures are really crappy because the dose is very low in each picture, right? So the sum of all of these pictures gives you a normal dose for one picture. So each picture is of lower quality, but high enough quality to measure fluid dynamics of how that's going on. Okay, great. And our Wednesday, we're starting MR, which is very exciting. I did MR for 30 years. It's awesome. And Tom's going to take over on Wednesday. So if you guys have questions about the whole CT thing, don't hesitate to shoot me an email and we can get together on Zoom or whatever. Okay.